Thank you for joining me in listening to my talk on compression fraction alone does not adequately measure CPR quality in out-of-hospital cardiac arrest. My name is Angelica Loza-Gomez, and I'm from the University of Southern California, Keck School of Medicine. This is my research team, which was a pleasure to work with. And we are composed of individuals from University of Southern California, University of California, Los Angeles, and University of Texas. I have no disclosures. Out-of-hospital cardiac arrest is a devastating occurrence, and we see about 356,000 cases annually in the United States. Survival is a mere 10% for survival at discharge. Moreover, neurological outcome is even more difficult to obtain, and quality CPR by EMS is very important for these reasons. Minimal interruptions in chest compressions maximizes survival with good neurological outcome to hospital discharge. CPR quality metrics currently focus on depth, rate, and recoil. In particular, recommendations focus on compression fraction, or CF, as a primary focus for quality chest compressions. Compression fraction is defined as a percentage of time compressions are performed during out-of-hospital cardiac arrest during a case. Compression fraction does not account for compressions in target, or CIT. That is a proportion of compressions at the recommended rate of 100 to 120 beats per minute and depth at 2 to 2.4 inches. The rationale for our study was to evaluate whether compression fraction correlates with compressions in target and out-of-hospital cardiac arrest. Our null hypothesis is that there is no linear correlation between CIT and CF. Also, CIT would not differ for events with high and low compression fraction, to be defined as high of greater than or equal to 80% or low of less than 80%. These are the general accepted markers for quality chest compressions and compression fraction, and also the recommended goal for quality chest compressions by the American Heart Association. This was a pre-hospital prospective observational study over the course of 9 months from January 1st to September 30th of 2019. Our inclusion criteria was adult non-traumatic out-of-hospital cardiac arrest, and 3 EMS agencies in the Los Angeles County in California were involved with the study. They were Downey, Montebello, and Glendale Fire Departments. Exclusion criteria were prisoners, pregnant female, DNR, a weight of 90 pounds or 41 kilograms, and a total CPR time of less than 3 minutes. Zoll X-series monitors were used for this study, and the purpose was to capture all data metrics as well as timestamps and other important data analyses as soon as the cardiac monitor was turned on and pads are placed on patient. Cardiac arrest data was saved on electronic clouds and immediately available for analysis. Target rate was set at 100 to 120 compressions per minute, and target depth was 2 to 2.4 inches. A Spearman's rank correlation was used for correlation between CF and CIT. A Wilkinson rank sum test was used for cases with a high and a low compression fraction. Our power calculation gave us a sample size of 85 cases to provide 80% power to detect a moderate linear association between compression and target and compression fraction. 120 patients met inclusion criteria, and the median age was 72.5 years old. Median weight was 74 kilograms. Our cardiac arrest characteristics shows us that we had 45.8% witnessed cardiac arrest, 42.5 citizen CPR. Our initial rhythm was primarily asystole at 52.1%, followed by PEA at 23.5, and lastly, VF of 17.7%. The total CPR time median was 22 minutes, and ROSC was 38.3%. Our CPR metrics show us that the average compression depth was at a median of 2.1 inches. Compressions at target depth was at 30% of the time. Average compression rate median was 118.5 minutes, and compression at target rate was 52.5%. Overall compressions in target was 13%, and compression in fraction was a median of 83%. Here we can see the correlation between compression fraction and overall compression in target, which is our primary question. We see here that there is no correlation with a Spearman's rho of 0.165 and a p-value equal to 0.072. Our secondary question was to determine if events differed for a compression fraction at acceptable range of greater than or equal to 80% and a low range at less than 80%. We see here that there is no difference between two groups for compressions in target. At 10% for compression fraction of less than 80%, and at 14% for acceptable compression fraction of greater than or equal to 80%. In conclusion, compression fraction was high at 83%, which is greater than the goal for high quality chest compressions at greater than or equal to 80%. Compressions in target was low at 13%. No correlation between compression fraction and compression in target was measured, either linearly or dichotomizing compression fraction as high or low. Our results question the current focus of compression fraction as a sole metric for CPR quality. Future larger prospective studies are needed to explore compression in target as an additional or alternative measure of CPR quality. Limitations to our study are a small sample size of 120, and also the fact that we did not have access to outcome on these patients to look at survivable at discharge from hospital and also neurological outcomes. This is the end of my talk. Thank you so much.